all of us in this nice place and in this very scientific atmosphere. Professor Dr. Hisham Al-Ghazali is a professor of clinical oncology at Ain Shams University. He is a general secretary of the Breast and Gynecology International Cancer Conference. He's a general secretary.
Thank you very much.
Okay, start, Dr. Hisham.
Thank you very much, Professor Heba, for this introduction. Thank you, Mr. Chairman. And it is my honor to be with you again in the 5th BGICC, and we will talk about the decision-making in chemo-targeted breast cancer therapy in 2013 after newly emerged data. The questions need to be answered in this lecture is what are the new emerging data in breast cancer management and what we understood from these data and how these data affecting our decision and what is the vision for the future. We divide this lecture in two parts, the early breast cancer and metastatic breast cancer, starting by early adjuvant targeted therapy. Very important question want to be answered, the duration of trastuzumab therapy, 2 years versus 1 year, and this is answered by the HERA trial, 2 years versus 1 year of trastuzumab after adjuvant chemotherapy in women with HER2-positive early breast cancer after 8 years of median follow-up, presented in the last ESMO. As we all know, the important HERA trial accruing about 5,000 of patients between 2001 to 2005, with pathologically confirmed HER2 positive either by immunohistochemistry blood 3 or by the FISH positive, and randomized either to receive 2 years of trastuzumab treatment or 1 year of trastuzumab treatment or observation, which this arm is switched to trastuzumab treatment after ASCO 2005. The disease-free survival for the patient receiving 2 years of trastuzumab is statistically similar to the patient receiving 1 year of the trastuzumab, and also the overall survival is no different between the trastuzumab in 2 years versus 1 year. They conclude from the study that there is no evidence of long-term benefit of 2 years compared to 1 year of trastuzumab when administered as sequential treatment following chemo, and also the secondary cardiac endpoint and other adverse events are more in the 2 years of trastuzumab arm. So the take-home point from this, the standard of care is still 1 year of trastuzumab. Another important question in the duration, whether shorter is better. So 6 months is like 12 months. This FAIR trial, the French trial, which based on non-inferiority hypothesis, the study design is after 6 months of trastuzumab, the patient randomized either to receive trastuzumab again for to complete 12 months or for observation and stop trastuzumab. Unfortunately, this study not met its non-inferiority level of hazard ratio of 1.15, and also in both disease-free and overall survival. The subgroup analysis presented in the last San Antonio showing that the sequential modality for estrogen receptor negative tumor impacting the overall results, while the results in other groups seems compatible with non-inferiority hypothesis. So in conclusion for the FAIR study, that she failed to show that 6 months of trastuzumab is non-inferior to 12 months, while in the subgroup analysis, the estrogen receptor negative tumor impacted overall results, and the other group seems compatible with non-inferiority. Longer follow-up in this FAIR trial and other trial like shorter and SOLT trial are awaited to explain these results. And again, the take-home point from this is still the duration standard of care is 1 year. Another very important analysis in the last San Antonio, the final blind joint analysis of overall survival between an SABB-B31 and NSCCTG and 9831, who analyzed the trastuzumab plus adjuvant chemotherapy for HER2-positive breast cancer patients. The original protocol of NSABP is 4-cycle AC followed by 4-cycle Taxol or paclitaxel every 21 days, and this is compared to the same regimen with concomitant trastuzumab on weekly basis. And in NSCCTG protocol, comparing the same chemotherapy with weekly paclitaxel to sequential or concomitant trastuzumab. In this analysis, the sequential arm is omitted from the analysis, and the analysis is between the patients who are receiving trastuzumab either with Taxol every 3 weeks or weekly with concomitant trastuzumab compared to the control arm, which AC, then paclitaxel either weekly or every 3 weeks. These results show that the overall survival, there is benefit from addition of trastuzumab, and the overall survival is maintained statistically significant over the control arm. Also, this benefit is shown on all patient subgroups, including age, hormonal receptor status, tumor size, nodal status, and histological grade. So, in conclusion from this study, that after follow-up of 8.4 years, the addition of trastuzumab to paclitaxel followed AC chemotherapy is associated with significant and substantial improvement in overall survival, and the relative risk reduction benefit for both disease-free and overall survival was present and similar magnitude in all subset of patients. And thank you for this molecule with maintained overall survival benefit. Going to another molecule, testing it in the adjuvant setting in the HER2-positive disease, the TITCH study studying the labatinib versus placebo in patients with HER2-positive disease for 1 year. And unfortunately, the disease-free survival is not met its endpoint. The study don't meet its endpoint, except in those subset of patients receiving the treatment in less than 1 year from the primary diagnosis, and those with estrogen receptor and progesterone receptor negative. Also, the overall survival not improved in this study by the use of labatinib. As we all know that there is increase in the side effect like rash and diarrhea in the labatinib arm, and disease discontinuation occurring in about 20% versus 6% in the placebo arm. We concluded that the adjuvant labatinib failed to show any significant statistical improvement in either disease-free or overall survival, and we consider this study is a negative study. Another trial trying to improve the outcome of the patients with triple-negative breast cancer by using the bevacizumab as adjuvant treatment. This study is presented in the last San Antonio about 1 month ago. Randomizing patients with triple-negative breast cancer, about 2,500 patients was randomized to receive chemotherapy, then followed by bevacizumab as adjuvant treatment for 1 year or observation. And the main finding of this study, there is no significant improvement in the 3 years invasive disease-free survival rate with the addition of bevacizumab to adjuvant chemo, and the lack of invasive disease-free survival benefit observed across all the subgroups with no significant and no significant difference in overall survival rates. So we feel that the bevacizumab in breast cancer may need resuscitation, and it may be, I think it may be dead already, but we try to another trial to find it an exit. In metastatic breast cancer, in targeted treatment in HER2-positive, the beautiful Emilia study studying the new molecule, the TDM1, a phase 3 study, the trastuzumab emtansine TDM1 versus capecitabine and labatinib in HER2-positive locally advanced or metastatic breast cancer. It is like this molecule is like the wooden horse in the Troy story, with the chemotherapy inside this wooden horse and going to the cells, releasing the chemotherapy and destroying by both mechanisms the this is the TDM1 with chemotherapy linked to the trastuzumab. The trastuzumab introducing the chemotherapy inside, and then the trastuzumab inhibiting the HER2 signals, and then the chemotherapy released by the lysozyme inhibiting the microtubule polymerization and destroying the cell. This is study design comparing between the TDM1 versus capecitabine and labatinib in patients with HER2 positive locally advanced and metastatic breast cancer. The first analysis was presented in ASCO 2012, presented the first interim overall survival, and the second interim overall survival was presented in the last ESMO, and the final overall survival analysis will be expected in 2014. The progression-free survival is better in the TDM1, 9.6 versus 6.4 months for the labatinib capecitabine arm. In the first analysis, the median overall survival is not reached, and the second overall survival in the confirmatory analysis was 13.9 versus 25.1 months in the control arm. And this is statistically significant results. And this improvement is appeared in all the patient subgroup, including race, number of prior chemotherapy, disease involvement, age of patient, estrogen and the progesterone receptor status, line of therapy. And also the beautiful thing, the duration of response in the TDM1 is almost doubled than the control arm. And also, very beautifully, the side effect is lower, especially the grade 3 and 4 side effects, which may include only thrombocytopenia, anemia, and increased liver enzyme. So in conclusion from this EMILIA study, there is significant improvement in progression-free overall survival. Time to symptom progression is also improved, and the safety profile is favorable to capecitabine and labatinib. And we consider this a very successful study and may change our practice later. Again, in last San Antonio, the confirmatory overall survival analysis of Cleopatra study, which is randomized study between bertuzumab, trastuzumab, and docetaxel versus trastuzumab, docetaxel in metastatic breast cancer patient as first line. The overall survival is maintained in the bertuzumab arm, which is better than the control arm of trastuzumab docetaxel, and also this shown in all patient subgroups. The progression-free survival is confirming the previous results that presented in San Antonio 2011 with improvement in the bertuzumab arm, also in all patient subgroups. The side effects of the bertuzumab arm including diarrhea, slightly febrile neutropenia and dry skin, and maybe mucosal inflammation and decreased appetite. So, in conclusion of the Cleopatra study, that there is a statistically significant and clinically meaningful improvement in overall survival with bertuzumab plus trastuzumab plus docetaxel in HER2 positive breast cancer as a first line. And the side effect is manageable, and maybe small diarrhea, rash, and mucosal inflammation. And we could consider this also as a success story in the treatment of metastatic breast cancer. So the clinic take-home points in early breast cancer that 1 year of trastuzumab remain the standard of care as part of an adjuvant therapy for patients with HER2 positive early breast cancer. Labatinib failed to show benefit in adjuvant setting except in subset of patients that may need further studies. No confirmed rule of bevacizumab in adjuvant setting in triple-negative breast cancer. And in metastatic breast cancer, the TDM1 offer an important therapeutic option in the treatment of HER2-positive metastatic breast cancer. Bertuzumab, it is a very important molecule and may change our decision and may change the practice in treatment of metastatic breast cancer cases. tailored treatment and more understanding of the disease will help in better achievement in our fight against cancer. And I think we understand the breast cancer before like this and now like this, and I hope in the future we understand the breast cancer like this and the picture will be clear. And please don't miss the clinical recommendation panel tomorrow at 7 p.m. about the neoadjuvant setting in breast cancer. And thank you very much.
Thank you very much, Professor Hisham Al-Ghazali, for your excellent talk and very informative presentation. I'm sorry again, there is no opportunity for questions. So now I'd like to present my colleague, Professor Dr. Heba Zawahri. She is chairing the